gonna get familiar with these definitions. And guys, this is something, it's like very basic information, and we are all nurses here, so we should have some knowledge base of precautions. Contact, airborne, droplet, and what to do. So we know like passive immunity, active immunity. We need to go over the immunities, or we're pretty good, because I'm not going to test on immunities in this exam. Okay, just know the basics. We have covered immunity a few weeks ago. This is your transmission, or like your chain of infection. Get familiar with this chain of infection. You will see it again. So it starts right here. Well, it doesn't start, it kind of goes on and on, but let's start here with the infectious agent, okay? So what is the number one thing that you will do right here to break this chain? Like bacteria, fungi, viruses, protozoas, like, hand washing, okay? If there is any indication of that you have been exposed to pathogens, bacteria or virus or anything, hand washing if you have touched, or so talking about this. You can contract these infections through direct contact, which is somebody sneezed on your face, okay, and or like indirect contact. So what is indirect contact? Surfaces, in a healthcare setting, patient's room, patient's surroundings, like, those tables, chairs, bed sheets, okay, in your stethoscope, you're carrying like lots of pathogens around. So we can break that direct or indirect contact chain right there. And number one thing is hand washing, hand hygiene, or sanitizing those surfaces. Okay. Then we have the reservoirs. The reservoirs are like what people, equipment, instruments, like, this is where your pathogen can come and live and then move up in the chain. Port of exit, the way pathogen leaves the reservoir. For example, if it's like the people, human, so think about your flu, okay? C. diff, think about the stool, okay? COVID. That's pretty brand new. So again, it could be bodily secretions such as saliva, blood, skin contact, skin membranes, droplets, okay? Transmission, again, direct, indirect, okay? So when it does exit, it can move to the port of entry through like direct contact or indirect, okay? Then we have our fomites and vector or airborne. So fomites are, what are your fomites? What is fomite? So when we're looking at fomite and vector, one is living and one is non-living. Let's open your textbook and find out what is the difference, what is fomite and what is vector.
Fomite is not living.
Okay. Animals, like, in our human cases are preschoolers or kindergartners. Animals, yes, and airborne. Then we have the port of entry, so your infectious agent at a party somewhere here, and a human being, equipment, water, food, then exited the party and then transmitted, and then they're going to look for a new host. Okay, that's port of entry. That could be mucous membrane. That's when you come in contact with those bodily secretions. Okay, so again, somebody sneezed on your face. Okay, or you got exposed to blood, fecal matter that is contaminated, urine, sexual contact, broken skin. Your skin is first line of defense. Eyes. Okay, eyes is like mostly for your droplets. Okay, and then the susceptible host. So susceptible host is the person who's like most prone to catching these infections. So we have our infants, their immune system is not developed all the way, so they can fight infections, okay? And then we have our immunocompromised patients, such as our chemo patients, patients on immunosuppressant medications. So who is on immunosuppressant medication? Cancer patient or the organ people, like, somebody with a donated lung or the kidney, okay? Then we have our elderly, their immune system is like not in commission. And then it kind of goes on. It will leave the susceptible, it will contaminate the susceptible host, and then find a reservoir, and the chain will keep going and on. And then as nurses, as healthcare workers, we are always trying to break this chain at any point. So it's like not getting around. I think we didn't do a very good job with COVID. Or maybe we did. It was a smart virus. So we all know what is your body's normal flora? It's your good bacteria. And once you lose your good bacteria, what happens? Who takes place here? Bad bacteria. Okay. Antibiotics. When your patient, let's say your patient has some sort of infection, let's say UTI. Okay. Maybe somebody forgot to do pericare on them for a couple of days, and then your patient is sitting with UTI, raging UTI, and we put them on antibiotics. So antibiotics, they don't care. It's a good bacteria or a bad bacteria. Their job is to kill the bacteria. So we are killing the bad bacteria, but we are also getting rid of the normal flora. Okay? When there is a change in normal flora, what happens? In your gut, especially. Your patient is at risk for what? C. diff, because we have killed all the good guys in there. Age. Okay, infants and older adults. Their immune system is not very strong. Skin mucous membranes, or a normal excretory secretions. So again, like going back to skin and mucous membrane, your skin is your first line of defense. It protects you from entering pathogens into your body. So when we're talking about skin and mucous membranes, think about your surgical patients, your trauma patients, or patients with wounds. Okay, that line of defense, that first barrier is broken. So they are at risk for contracting anything and everything they will come in contact with. Okay? So whenever we are doing the wound care, around their surroundings, we want to make sure everything is sanitized, clean, and no anyone who's sick is not entering their room or exposing them. Hormonal factors, okay, environmental factors, and medical interventions. So now we know just the basics, methods of transmission. First, we have contact. It is direct or indirect contact. Okay. We have droplet precautions, airborne, vector-borne, for example, like insects and animals. So that rabies is like one of the vector-borne disease. Environmental, we have contaminated food and water. So let's say you're working in hospital, okay, breakfast tray is served, and your patient was sleeping, or let's say they went for a procedure, and you're trying to be nice and you're holding on to their breakfast tray, so when they come back and we can serve them. It took them about like a couple of hours to get back to their room, and then we will serve them this food, like eggs or fresh fruit, whatnot. Do you think you're exposing your patient to some sort of bacteria here? Yes. Okay. Yes. So again, like when we are serving food, make sure it's at the right temperature. It has not been sitting out. With the foods, that's like one of the most common carrier of pathogens, especially in healthcare settings, because we do not consider it like it could cause infection because it has been prepped in a very clean environment, and then it's just sitting here, nobody touched it. But then think about those biofilms being made, on this food. Okay. portal of exit, okay, how the organism leaves, okay, is it droplet or contact or airborne? Our physiological defenses, first is our skin, then we have our white blood cells. When phagocytosis happen, our white cells are in action, they will cause inflammation. Actually, inflammation is your body's protective response, okay? And then we have our immune system. We have antibody-mediated immunity and then cell-mediated. Do we need to talk about this again?
Is it gonna be on this test?
No,
Okay.
no. But again, we have covered these immunities, okay? We have covered these immunities, so just be familiar because you will see them again on your comprehensive. So the goal is just not to prepare for one exam, for your comprehensive and the NCLEX. So health promotion and maintenance. Healthcare associated infection acquired in patient setting that is not present at admission. So give me examples of some of the hospital acquired infections. UTIs, pneumonia, MRSA. MRSA it could be also like community as well.
C. diff, because you go from one room to the other and you're like, oh crap,
Yep.
literally crap.
So again, any infection with that, like let's say if you admitted a patient with no infection, and then 2 days later, they have developed some sort of infection while they're hospitalized, that is your hospital acquired infection, okay? Pneumonia is number one. If your patient has a central line, then CLEBC, the central line bloodstream infection, is another common one. If your patient will end up with an inbound catheter, then they're at risk for UTI, hospital-acquired UTI. Endogenous infections from the patient's flora, exogenous infection from outside the patient, okay, often from the tubes, implants, or healthcare workers' hands, okay? So this is what we are trying to protect right here. C. diff is an example of the endogenous one, okay? Because we have killed their good bacteria. For this one, let's say those Foley catheters, okay, IVs, what else? Incisions, or if you are not doing a very good job washing hands. Okay. So we are the vectors in a hospital care setting. Yes.
So is C. diff normal in people? Is smaller amounts?
So with the C. diff, it's like if, let's say, if your patient has, one patient has a C. diff, you went and did the cares, forgot to wash hands, and then you will go to a next patient, then you're going to put them at this risk. Because they're not on antibiotics or anything, we are just kind of like exposing them from a different room. If your patients develop C. diff from antibiotics, okay, we put them on antibiotics and we wiped out all the flora, good flora, bad flora, but then, now they're susceptible for infections for the C. diff. First line of defense, clean hands. Do we remember like our skills lab, washing hands? I think this is the first thing we teach in nursing school. And washing.
What are you doing?
So methods of infection control and prevention, hand hygiene. Okay, disinfection and sterilization, what is the difference?
Co-engineer. Focus.
Estella, huh? Yeah. So what is the difference between disinfection and sterilization?
Disinfecting is, sterilization is complete, killing of all germs. Disinfection is 99.9%.
But what are the methods? Let's look into your textbook, what are the methods? So when we're talking about sterilization, the one thing I can give you is the autoclave in the surgical OR setting, okay? Disinfection.
Disinfection autoclave.
So it doesn't kill the spores, but ensures a reduction in the level of disease-causing organisms.
Yes.
Good job, engineer.
So when we're doing any invasive procedures, we are making sure we are maintaining what? Sterile field? Those, when we are inserting Foley catheters, what is the number one thing we are being mindful of? Cross-contamination and not breaking that sterile field, okay? If you will break that sterile field, what is going to happen? Infection, UTI, your patient will end up with UTI. Okay? Then we have our standard precautions, that is hand washing, transmission-based precautions, so the lady did a really good job, don't worry about those mnemonics. Airborne, droplet, and contact precautions. Staff and patient placement and cohorting, right here. So if you have a patient with infection, let's say MRSA, okay? And you just got a call from ER that we are admitting another patient with influenza, okay? Can we cohort these two patients, MRSA and influenza? Can we put them in the same room?
No.
No, why not? They're both infected.
Different diseases, one is drop flu, one is contact.
It doesn't matter if it's a contact or if they're both airborne, but they're two different
Because they're not the
organisms.
same-
They're
it's
two
not the
different
same
pathogens,
infection.
two different infections. So the person who has MRSA will end up with flu, and the person who has flu now will have MRSA, so. But we can always cohort a like infection. So let's go back to MRSA. You have a patient with MRSA, got a call from ER that we are getting another MRSA patient. We can put them in the same room. Okay, we can cohort them in alike, like alike infections can go into same setting, same room. Okay? Please remember that. So these are your PPE visuals for droplet, airborne, contact precautions. This is your MRSA, multi-drug resistant organism infection in, MRDOs. So there are 3 types of drug resistant organisms. Your methicillin resistant, vancomycin resistant, and your carbapenem resistant. Please remember these 3. They're like only 3 drug resistant organisms. MRSA, VRE, and CRE. VRE and CRE, they're like common in urine, okay? When your patient has UTI and then we will run a sample, there is a chance, like, you're looking for VRE or CRE, okay? The meaning is that they are not responding to, like, VRE is not responding to vancomycin, and the carbapenem is not responding to carbapenem, but with the CRE, it produces an enzyme that breaks down any antibiotic, so it's kind of like hard to treat, and they're like pretty contagious. With MRSA, on the other hand, it depends, okay? Where is the MRSA? What is the source of infection? Is it respiratory? Is it skin? Is it urine? Is it stool? What is it? And then from there, we will put the precautions in place. If it is respiratory, then what precautions we will have in place? For respiratory, do we just go with contact precautions?
No.
No. What precautions we're looking at then?
Droplet, possibly
Droplet,
airborne.
airborne, okay, just depending. Okay, if it is skin, a wound, then which precaution? Contact precaution. Okay, so with MRSA, it kind of gets tricky. If you will give me a report, this patient has MRSA, okay? I will ask you where. Okay, what is where is this MRSA? Say, okay, it's in the wound. Is it contained or it is uncontained. If it is contained, then we can go with standard precautions because you are not exposed to this organism. Okay? If it is uncontained, okay, let's say it's in the wound, and that wound is open to air, and there is drainage, now you are exposed. Now you're going to get exposed to MRSA, and then you are at risk for having this pathogen. Okay, so let's say if you have a patient with a wound, and we did the cultures, they came back positive for MRSA, and then now they have to go get some procedure done. Okay? What will you do? How you will contain this?
I mean, you will make sure that it's covered.
We will make sure it's covered. We will put like a dry dressing on it. Okay?
And
When
I
the-
wear a gown, I don't, I'm sorry, we're not going there.
Yeah. Like, you know, again, like when it comes to precautions, we have standards, like for each precaution, we want to follow that, but then if, like for me, I wear gloves and gowns for anything and everything. I don't
Well,
know.
because the old people that have it touch everything, I'm just like,
They touch everything.
those phalanges are not too close to.
So with, let's say for MRSA, your patient is going for a procedure, what are you going to do? You're going to cover this wound, if it's in the wound, with a dry dressing, so when they are walking through the hallways or being transported, they are not exposing anybody or whoever is going to work with them.
That scares me.
So with the wound one, if they have a dressing in place, but now you see some drainage on the dressing, it is not contained at this point. It is not contained at this point because there is drainage and the dressing is not doing its job.
I have a question for you.
Yes.
Marcia. So what about when it's in the urine?
I was about to.
Oh, okay,
Jump
just
there.
kidding, but yeah.
So if it's in the urine, let's say if your patient is continent, they are able to go take care of their business, we are not exposed to the urine, like, you know, then we consider it contained. Then we will consider it contained because we are not getting exposed to their urine, the bodily fluid. If your patient is incontinent, okay, now it is not contained because anytime you will go change that brief or do the pericare, you are getting exposed. And then you will follow the contact precautions. If your patient has an indwelling Foley catheter, it's contained until you're going to go clean that Foley catheter bag out.
So we just put on a condom cap too,
But again, like, you know, if they have a catheter, anytime you're going to open, you know, then it's not contained.
Is this gonna be on the test?
Yes, that's why I'm spending too much time here explaining contained or not contained.
I have a question.
Yes.
So what if the MRSA is in the mirror?
Then it's respiratory.
Would the, you can't go for the same, the patient with the MRSA for one like that?
No. But if they have like both MRSAs, then yes, you can. If they have like, it's the same organism. No, I'll take it back. No, I'll take it back. I'm just kind of confusing myself. No, still, because the mode of transmission is different. Is different. Just kidding. But if there is a test question about multi-drug resistant organisms, just remember these are the only 3 drug resistant organisms. Any statement that is part of this question is not going to be a true statement. And I'm going to leave it to you guys if you know how to break down those questions, if I'm asking for the right statement or the wrong statement.
Oh, yeah, that's my problem.
Okay? Sorry, and I cannot give the answers here now. I'm doing,
But I,
but just remember
at
this
least I
slide,
figured
okay?
out what my problem is.
Remember this slide.
I can't believe.
So again, this is your MRSA, spread by indwelling urinary catheters, vascular access device, open wounds, endotracheal tubes. Then we have our community associated MRSA. So the health teaching we are going to do is frequent hand hygiene and use hand sanitizer. Avoid close contact with people who have this infection or infectious wounds. Avoid large crowds. Avoid contaminated surfaces and use good overall hygiene. Then we have our VRE and then our carbapenem resistant, CRE.
That's in the gut.
It's the contact precaution. So in my experience, anytime I came across VRE or CRE, it was in urine. Sometimes it could be in blood, but like the most common source is urine.
Look it on the book says intestinal.
Could be. Occupational and environmental exposure to sources of infection. That's why we follow those occupational OSHA regulations. Reduction of bloodborne pathogens transmission. Possibilities of pandemic or biological agent exposure. So give me an example of one of the biological agent exposure. Biological agent. It was pretty common back when I was in college. Huh? Anthrax, yeah. Animals or insects are also sources of infections. There are mosquitoes, okay, rabies. Gangrene is from the soil, that gas gangrene. The reservoir is soil. Then we have emerging infectious diseases and bioterrorism. COVID is one of them. Well, it's not bio, it's more kind of a viral, but anthrax is an example of bioterrorism through the contaminated food. C. diff is through direct contact, fecal, microbiome, transplant. So anybody familiar with FMT?
Is that where they put the fecal transplant, like either the injury to the whatever, where they
It's like a treatment, right?
It's a treatment.
It's a treatment.
FMT is a treatment
It's like
for C. diff, severe C. diff.
Yeah.
If they are not
Somebody
responding to any
else's.
treatments.
They put someone else.
someone
They-
else's
yeah.
food that you
So
do.
then you will have like a donor poop
That is so.
to restore your gut's normal microbiome. Okay?
Yeah, they did it through a nasal, through a
Pardon me?
nasal, one time and I threw up.
How would it work if it's
I'm
not
sorry,
your
excuse me,
normal?
I threw up.
Someone you live with and then they
But
tested
they
like the
have to,
person
they
who
have to restore.
sample your genes, they don't have any infection going on. They're gonna go through the testing.
Whenever I need to lose weight, I'm gonna have a fecal.
So problems from inadequate antimicrobial therapy, incorrect choice of drugs, okay? Inadequate dosing, so that's why we do those cultures and sensitivities. So when we do that culture and sensitivity, it tells us exactly which bacteria we are dealing with, and the sensitivity tells us if this bacteria is going to respond to certain medications. If it is sensitive, then yes, we're going to go treat that bacteria with that medication because it's going to respond. If it shows resistant, for example, like those VRE, it's resistant to vancomycin, so I will not touch that infection with vancomycin, knowing that it's not going to respond to vancomycin. Non-compliance and adherence, this will be part of your exam. So give me an examples of non-compliance and non-adherence when it comes to,
You don't finish their full antibiotics.
okay, not finishing the antibiotics, not taking the antibiotics. What else?
Is it like reading against,
Huh?
is it like reading against doctor orders, is that what you mean?
That's AMA, that's like problem for anything. But for antibiotics, like, let's say you finish your course and there's some leftover and there's like, let me just put it in the fridge and then I'll use it next time.
Yeah.
Or for somebody. Okay, I will give you an example. Years ago, I have a family friend, she came from India, she's a nurse. So she brought her own stash of medications, including antibiotics, just in case, and she will need them, okay? They had like a 1-year-old daughter, and this kid had, I don't know, maybe flu, some viral infection, and now we were giving this kid that antibiotic they brought from India. It was not helping. Why was not helping?
It wasn't appropriate for the type of.
But then it's like a viral
It's a
infection.
viruses can't have antibiotics.
So if it's a viral
Viral
infection, you
infection.
cannot give antibiotics. It's not going to work. You only give antibiotics for bacterial infections. So what happens, like now this kid is sicker, okay, and then they got dosed on these like antibiotics for so long, and now she has like, few resistance going on. So don't ever start taking antibiotics just because you have
Stop
it.
going to Mexico and bringing myself penicillin.
Yeah, don't do that.
Is that what you're telling me?
Yeah, or stop cooking something in your kitchen, like, just let something go moldy and then that's your penicillin right there. Okay. Bacteria, that's your bacterial infection in the bloodstream, septic shock. Okay, this is the one that will cause like septic-induced distributive shock that's more systemic. Assessment. So history, so we have that subjective data that we will collect, for example, like in case of infections. What are some of the subjective questions, some of the subjective data that you will collect if your patient's presenting with some sort of infection? Adriana.
Onset, what did you first notice that you started feeling differently? Anything that alleviates it, honestly, PQRS.
Any recent travels? Have you been around somebody?
What have you been doing? Did you notice it actually doing something?
Then it will kind of like, that will go to like, if it's respiratory, then we will focus our subjective assessment into that course. If it is, intestinal, GI, then yes, like, we will think about like food poisoning or whatnot. For respiratory, we will like, if they have been around somebody who was sick, okay, large crowds, recent travels. Then we will do the physical assessment. Psychosocial assessment. Okay, one of the biggest risks is what? Isolation. Think about quarantine. Then we have the laboratory assessment. Please remember this part right here. For the laboratory assessment, we will do the culture, and then the antibiotic sensitivity, we are doing cultures to find the organism, which organism is the culprit. Sensitivity, how to treat this organism. Let's say you have a patient, they came in with all the signs of infection, okay? And physician ordered broad spectrum Rocephin along with blood cultures. Okay, so you have these two orders together. Which order you will execute first? Collect the specimen first, okay? Both of those interventions are correct. Of course, there's infection, and I want to give my patient this broad spectrum. I want to give my patient this broad spectrum Rocephin because I want to treat this infection, but then now my physician also wants blood culture. So I will do the cultures first, then do the Rocephin. So why we are collecting the cultures first?
So you don't kill off the bacteria?
So we are not going to kill the bacteria, we are not going to deviate any of those results, any of those findings. So culture before we do antibiotics. Remember that, please. Both of the interventions are correct for infection patients. But if you have a choice to do cultures and give antibiotics, do the cultures first. If you're you're suspecting UTI, but then you have an order for antibiotics, get that urine sample first, and then give those antibiotics. Okay? white count. We all know what happens to the white count. It increases. Okay, your ESR will increase. And then we do like serological testing. That's your PCR testing. Then imaging assessment. Planning and implementation. We are moving into the management, like the nursing interventions part, from the nursing end, how we are going to manage this patient. Fever, so knowing if your patient has infection, they will have fever, okay? We will eliminate any underlying causes of fever, for example, like hyperthermia. What are some of the underlying causes? Like, think about environmental. We walk into a patient's room and then we take their temperature, it is 100.1, okay? Will you do further investigation, or you will just take your number and run with it? Further investigation, what investigation?
Maybe rechecking.
Huh?
Rechecking it
Recheck it?
after you lower the temperature. After you normalize the temperature.
Okay, so the further investigation is like, yes, we will recheck it, but you want to feel for it, like, you know, how the environment feels. Maybe they have their thermostat like, you know, up at like 85 or 90, okay? If they're sitting in this like hot burning room, their skin is obviously going to get warmer, their core body temperature is going to go up. And when you will scan them with the thermometer, they are going to read higher number, okay? Another thing is like the layers, the number of blankets they're hiding under, okay? That is one of the, another culprits. So look at layers. If they have like those 7, 8, 10 of those warm blankets, it's going to increase their core body temperature, okay? So then if it is just that if you will do the investigation, you think it's environmental, try to fix those environmental factors, okay? And then you check it. But then if there's like nothing, there's like no other issues, your patient has infection, you're going to treat it, okay? So with the fever, when the body temperature goes up, it is killing those bacteria. So as a nurse and a mother, anytime my child has fever, it makes me happy. Why is that? Am I crazy? No, it makes me happy because, hey, it's telling me their immune system is working, okay? They're fighting some sort of infection, you know, in a natural way, okay? Then we do drug therapy, okay? Antipyretics. What is the common antipyretic we use in healthcare settings? Tylenol, okay? If your patient has liver, bad liver, ibuprofen. Okay, external cooling. So this is the one trick I learned, external cooling, when I was in nursing school and my daughter, I gave her RSV after my clinical rotations, okay? So she had like pretty high fever, and I don't know, but maybe Muskan and Kamal, they can agree with me, like in our culture, it's like somebody has a fever, just cover them up as much as you can. Sweat it out. But again, like, you know, it was like making her temperature go up. Yes, like when we wanted her to sweat out. So my PEDS instructor, she's like, no, just give her, you know, a cold bath. It will help bring down her temperature. It will help bring her core temperature down. So in this case, we can maybe lower down the thermostat, kind of make their room a little cooler, give them an ice pack, you know, or maybe like a shower, like a cold shower. That helps. Huh?
Poor kid, you gave her
No.
that and you're happy that she's got fever.
I was happy. Like at the time I was not. I was a new mother and then I was not a nurse. So I was just kind of like in the nursing student panic mode. Right? Like we can relate. We can relate. Fluid administration. So your patient is at risk for what? dehydration. So we want to make sure we are giving them enough fluids to stay hydrated, because dehydration will further cause more complications. Alyssa. You were about to check out, sorry. Care coordination and transition management. Home care management, if your patient is going home with antibiotics, let's say IV antibiotics, they need IV antibiotics for, let's say, maybe another month or so, they have, a weird, like a infection, then we will have home care management. There will be a home health nurse checking on them, maybe once or twice a week. And then we also teach them, how to take, if you're sending them with a PICC line or something, then we will also teach them how to take care of the PICC line, and then how to initiate and then stop those infusions on their own. And then healthcare resources. And we will collaborate with case management, social services to allocate resources out in the community to help manage their cares at home, okay? Do we always send people, patients home with IV access? Okay. In some cases we do. In some cases we do, okay? If they need a long-term care IV antibiotics, okay? Just like not peripheral IVs, because we know that the peripheral IVs, they are at risk for infections, because those IVs, they're not good forever. So we will put some sort of a large, long peripheral, PICC line or the central line. But we're going to teach our patients how to prevent those CLEBSIs. Evaluation. Now we're going to evaluate the care of our patient with infection. So you have assessed, you implemented your care, and then you're going to evaluate if your plan of care is working. Evaluate the care of patient with an infection on the basis of the identified priority problems is important, so that was your goal. Okay, the expected outcome include that the patient, if it was the fever, that was your high priority, then your goal, you're evaluating has the body temperature and other vital signs within baseline, okay? And if your patient was on antibiotic therapy, then you're evaluating if your patient was compliant with their medication regime. Okay, a 27-year-old patient is admitted from the ED to the medical surgical unit with cellulitis of the left leg. The culture result from her primary care provider's office indicated that her left leg wound was positive for MRSA. Based on this information provided during the SBAR report, what type of isolation room should the nurse prepare for the patient when she arrives on the unit? Contact. After a patient is settled in her room, what special precautions does the nurse implement based on the patient's diagnosis? So we are still talking about MRSA.
You can wear gloves when entering the room.
Equipment use population. BD.
Okay. Wear a gown. Dedicated equipment should be used for this patient alone. Okay, so same patient with MRSA. An hour later, the nurse is preparing to administer the patient's medications. Which drug was likely ordered by the provider to combat the patient's MRSA? It was part of our slide. The vancomycin. After lunch, the patient asked the nurse how she could have contracted the MRSA infection. What is the nurse's best response?
D.
MRSA is spread by direct contact in hospitals and communities. A nurse is conducting a hand washing refresher session, for which situation will the nurse remind all staff that cleansing hands with an alcohol-based rub is appropriate.
After handling oral medications too.
Yep. Only after you have handled the medication, after you use the bathroom, like, can you just kind of like do an alcohol rub and then mind your business?
Ew.
No. How about like if your hands are visibly soiled? No. How about C. diff? Can we just, with the C. diff, so why we encourage, with C. diff, why we encourage soap and water? We don't encourage, we enforce soap and water only. If you have a patient with C. diff and let's say Kamal came out of this room and then he just went for the dispenser, alcohol rub dispenser, okay, how will you correct him?
Can you please go wash your hands before you head this way because we're
With soap and water.
My brother in Christ, I don't want to be stuck in the toilet, please.
I do tell the doctors, I'm like, hey, you wanna hit up the sink real quick?
Yeah, but again, like why with C. diff? Like, you know, why we get
'Cause
like
you need to
so
wash it
Because
off
you need
rather
soap
than
and water, it
alcohol
doesn't come
will
off with the alcohol.
kills the spores. Alcohol
Oh,
is not going
well,
to
your
kill the
big word,
spores.
yeah.
Okay, soap and water and good friction is going to kill the spores. Okay, spores, with any infections, we are trying to kill the spores because these are the culprit that are getting transmitted from one person to another. With C. diff, good hand hygiene, soap and water with good friction is going to kill the spores. Okay,
You know what's worse? Isn't it like the doctors, the ones that do like the less of like the actual?
yeah. Well,
I'm like,
when I was working night shift, we had a nurse, Trey. He was like, you know, very OCD about hand washing. Like, you know, those people actually timed the hand wash. It was 5 minutes. It was a 5-minute hand wash. If you would see his hands, it was like literally like this color all the time, or like maybe darker than that. Night shift, it was working out, like, you know, because he was working with us and we kind of knew, like, if Trey's at the sink, nobody's going to bother him. He's going to wash his hands and we appreciated it. We having just one male on our team and then he's like very meticulous with hand hygiene. I'm not pointing at any of the guys here. I mean, but, so like Trey, like, you know, he decided to go to day shift. And one time he left a physician on hold for 10 minutes because he was busy washing hands.
Minutes?
We appreciate it, but then again, like, you know, there is a time. 20 seconds is good. 20 seconds to 30, maybe a minute is good. Okay? When caring for 4 clients, which clients does the nurse identify at highest risk for infection?
Oh, wait.
So, with the stomach pain, C,
I think steroid.
steroid tapers. Like anytime somebody is on steroid, corticosteroids, their immunity is not up to the speed. So anybody who's on steroids is also at risk for infection.
It's just
it's somewhat introducing.
The kidney disease? Why is that? Like, what is the rationale? There is rationale right here. Like, no, I would like go with the steroid taper. The client's immune system says
Like, this is like long-term steroid dependence.
yeah, but then again, like, you know, just like chronic kidney disease, it could be from anything. I'm sorry, guys, I will stick with B here. Oh, sorry, I will stick with C, with the steroids. 10-day steroid taper.
Is it because it's deeper?
But still, like, you know, with the chronic, this is, okay, if this is an elderly person with a chronic kidney disease, then, then we can say, like, you know, okay, with the age and then the renal function is not up to date, their immunity is not up to speed, and then they're at risk for what, like maybe retention or like, you know, not filtering out things, but this is like,
They're more important.
huh?
They're more important toxicity.
Yeah, yeah. So, cause like in everything, like to me, like when it comes to steroid, if they're like on like steroids for 10 days, then somewhere. Okay, let's move to, when caring for a client with MRSA, which precaution will the nurse institute? Okay. Let's take a break. And please know about all kind of precautions.
So can I just like real quick, you said all the precautions, contact droplet,
Airborne,
airborne,
standard precautions.
standard precautions, direct and indirect, herpes zoster pain, MRSA contained, uncontained, treatment and caution,
Yeah.
drug resistance and chain of infection,
Kind of infection.
antibiotics. Thank you.
Okay. 48, assessment of the GI system. There are 2 videos right here, just gonna watch them in your own time. We're going to skip over the basic anatomy. I'm giving everybody the benefit of doubt that we know the basic anatomy of GI system. Okay, GI changes associated with age. There's a gastric mucosa atrophy. With this atrophy, your hydrochloric acid decreases. And when the hydrochloric acid decreases, it decreases the absorption of what? Iron and B12. And with the less acid, your patient is also at risk for bacterial proliferation, causing gastritis. Okay, so think about it like, your gastric acids, they are also like fighting any bacteria. Then we have decreased peristalsis. What is peristalsis? The movement of like food, going through your GI tract. So with the age, the sensation to defecate decreases because your peristalsis slow down. It will lead to constipation and impaction. So in simple words, with age, your elderly patients, they are at risk for what? Constipation and fecal impaction. That's why we are always checking for those, they're doing the GI assessment because now they have, with the decreased peristalsis, also has they have a dull nerve impulse because of the age. So they don't feel they have to go poop as much as they can. Anybody working in long-term care, it's kind of like a running, I wouldn't say it's a running joke, but then it's something like, that elderly, as you age, as your patients age, they get very fixated on their bowels.
Yeah.
Anybody? Okay. I can give you an example of my dad. As he's getting older, he's getting very fixated. Okay. In my experience, elderly patients, majority of them, they get fixated, with their bowel movements. I had a patient one time, he would count that he's supposed to have 2 bowel movements every day. If he had only 1, he would panic that something is wrong. Something is wrong. So we can implement patient education, but just remember that the nerve impulses are diminished and their peristalsis is decreased. So they are at risk for constipation and infection. Then we have the distension and dilation of the pancreatic ducts. Okay. So the calcification of the pancreatic vessels occurs with occurs with age, and it decreases the lipase production. With the lipase production going down, your patient is not going to absorb fat, so their fat absorption is going to go down. So, therefore, they will may have fatty stool. What is the word? Okay, what is the clinical manifestations? What does the fatty stool look like?
It floats.
Huh? Okay, and it floats. It's kind of like a little frothy. It floats. Okay, decrease in number and size of hepatic cells. Okay, so with the decrease in number of hepatic cells, this is what is hepatic. It pertains to their liver. Okay, it kind of decreases their drug metabolizing abilities. Any drug that is getting metabolized through the liver. Okay, so therefore, if their hepatic cells decrease in number, their hepatic function is going down, they are at risk for what? Possible drug toxicity, any medication that is getting metabolized through liver. One is the common one is that we use. Tylenol is one of them. Disruption of microbial balance of good anaerobic and aerobic flora. That could put them at risk for infections, like, such as C. diff, because of if they will lose their normal flora. And it can also contribute to obesity, inflammation, disease, inflammatory disease, and reduced immunity. Let's say you're assessing your patient history. Some of the questions you will ask in subjective data collection. History, change in appetite. Have you noticed change in appetite? Decrease, increase? Okay. Are you eating more than your body requirements, or are you eating less than your body requirements? And what determines this question? When you weigh your patient, okay, their BMI. If it is less than normal, then we will question if they're eating less than what their body requires, maybe decrease in their appetite. If their BMI is over than their normal, then we will question maybe they're eating more than what their body requires. Okay? So maybe they have enhanced appetite. Weight, stool. Okay, so for the stool assessment, this is the assessment we do like pretty much every day when we're working bedside. Some of the questions you will ask your patient. Stool.
Color, texture.
First, we will start off with, have you had a bowel movement in the last 24 hours? If they don't have a poop in the last 24 hours, or if they're not pooping, they're not going to tell you if it's formed or not. Okay? So always check if they are defecating, if they're making stool. If they are not, then we are concerned. What was the last time you had stool? Okay? If they are, how many times? Like, again, everybody has a normal, everybody has a baseline. Once, twice, okay? Then we will look for what? The size, small, medium, large. Consistency, form, loose, color. We'll check, assess their age, gender, culture, any GI disorders or abdominal surgeries. We will check for that if they have a history of, let's say, colitis, IBS, diverticulitis, any liver disease, okay? Any abdominal surgeries, gallbladder removal, any exploratory laparotomies. Medications, herbs, and supplement. Okay, so medications. Some of the medications, they can cause constipation in your patients. Give me an example.
Opioids.
Opioids, pain medications, what else?
The ones that dry you up, what are they called?
Your ACE inhibitors,
Thank you.
anticholinergics.
Yeah, those.
Okay, now you know your patient with the gastric mucosa atrophy, their iron absorption is low, so maybe your patient is on iron supplements, so iron is also known for causing constipation,
And a
And-
different color poop.
different color poop. So that was just for the constipations, but then sometimes their medications, they will be causing the opposite. If your patient is having constant frequent diarrhea. We just talked about what, antibiotics? If your patient is on antibiotics, okay? Anytime your patient is on antibiotic, let's say your patient has UTI, your physician give an order for Zosyn IV antibiotics. Okay, what else you want to make sure that should be on patient's mark? Along with this antibiotic to prevent the loose and seizures. Probiotics, okay, that's kind of like a nursing judgment, like most of the time our doctors, they forget. They're just trying to treat this infection, they're like not thinking through, most of the time they're not thinking through, like, you know, I'm just treating UTI, but maybe I will cause a bigger problem. So as nurses, we are catching them in their trails and making them reroute and then give us appropriate plan of care. Because at the end of the day, you're what? Your patient's advocate. You're your patient's advocate. Okay. Herbs. Any herbal supplements your patient takes? Your vitamins, minerals, okay? Just kind of like read through your textbook. I'm not going to test you on, but please know it. Just some of those herbal supplements and vitamins and minerals. Smoking or vaping history, chewing tobacco, travel, and their nutritional history. So for the travel, what are we checking for the travel? What are some of the questions? Where are they been? What are we looking for here? Okay, if they have any type of like intestinal GI infections going on.
What food and stuff they ate.
Yeah. And for their nutrition, their eating habits, their diet. Their alcohol intake, caffeine intake. So with the caffeine, we know what is it? Huh? It's diuretic. It can cause dehydration in some of your patients. If your patient is dehydrated, losing fluid, they can be constipated as well. Because what happens with the adequate hydration? So when all that food goes into your into your colon, that's where it absorbs like the water to kind of like, you know, lubricate the stool so it can pass through. Drink water, please. Their socioeconomic status. So again, we will go back to tie it with their like nutritional history. Okay, if they can afford healthy, nutritious food or not. Family history and genetic risk. If they have a history of any GI disorders. If they're predisposed. Any current health problems. Weight, any changes in weight, appetite, or intake. Again, if they have gained or lost weight recently, any change in their appetite, increased or decreased, and what their intake is like. So, since we're talking about nutrition, so there are 2 eating disorders that we get concerned about. Anorexia and bulimia. Okay, so with anorexia, it's common in mostly like females. Okay, bulimia, what is bulimia? It's kind of like binging and purging? Throwing up, like, you know, they eat and then they throw up. So anybody who's anorexic or have eating disorder, especially like your female patients, what is the major health concern we can run into? Change in their menstrual cycle, missing menstrual cycle, because if their body weight or if their BMI is too low, or if they have lost that adipose tissue. And because in that case, your body's just trying to keep you alive, your body's not trying to think of any other function. That is not vital. Pain with PQRST mnemonics. So from your health assessment class, I'm assuming everybody's familiar with the PQRST mnemonics. If your patient is complaining of abdominal pain or ache. Physical assessment, please know the sequence you will do your abdominal assessment. So what is the sequence? Right here, the sequence. So, physical assessment, first we will start with what? Inspection. Okay, and you're inspecting the skin. Really, you're just gonna jump into percussion and palpation before you will do the auscultation or inspection? So the sequence of your physical assessment, inspection. So when you're inspecting, what are you looking at? Their skin, okay, symmetry. Okay, are we looking at any bulging on one side or other? Okay, any discoloration, distension. Is it flat? Is it distended? Bulging flanks. Where's your flank area? Lower back. Okay. Skin folds. So after we are done with inspection, we will move to the auscultation. What are we doing when we are auscultating? Assessing for the vowel sounds. So when we are doing the auscultation, we will start right here. We will follow the flow of your colon. You will start in the right lower quadrant first. Just think about your colon. Okay, your ascending and descending colon and your transverse colon. Then we will move to the right upper quadrant. We will auscultate. After there, we will move to the left upper. And at the end, it will go down to the left lower. Okay? So when we are auscultating, what are we auscultating? Vowel sounds. Hyperactive, hypoactive. Okay? These are hypoactive vowel sounds. What are you concerned of as a nurse? Hypo. Hypo. No. Ileus, constipation, any type of blockages. So the reason why we auscultate a stomach like in this fashion, so when we're auscultating, for example, like normal vowel sounds, hypo here, and then when I moved all the way down, absent. So that will tell us like maybe where the obstruction might be happening. Okay? So then we will move down to and hyper will be for diarrhea. If your patient has diarrhea, or you will hear hyperactive vowel sounds. Then we will do the percussion. Okay, palpation is always last. Because when we are palpating, what are we doing? We are like feeling for the organ sizes. We're looking for any inflammation. Or any masses or tumors, yes. Okay. So for percussion, that's performed by the healthcare provider. Okay, but with the palpation, we are assessing for the size and shape of the organs. So which organs are we palpating for? Liver, spleen, what else? Can you palpate poop?
What?
If your patient has obstruction?
Yes.
You can feel that it's really firm
Yep.
and gross.
Firm and gross, yes. Try to do palpation on yourself first thing in the morning, you will feel it.
Really?
Yes.
I'm about to go tomorrow.
Yes.
I'm gonna ask my husband.
Okay, so the percussion is performed by healthcare providers. So when we're doing the percussion, we are looking for the masses, okay, any hard, firm areas, or any masses there. But for your exam, please know the sequence of this assessment. Then we have psychosocial assessment. So again, like how many of us are comfortable talking about poop on a daily basis with strangers?
Can you go back to the other slide real quick?
You said palpation is the last one.
Thank
so
you.
he's probably gonna ask you for the exam. That's the slide.
No, and at least that one I'm just gonna have to reread it and reread it and reread it, the same stuff isn't sometimes.
Okay,
Thank you.
so again, for the psychosocial assessment, when we're talking about psychosocial assessment, like not all the patients, especially your elderly patients or your adolescents, they are like not very comfortable talking about their elimination patterns, okay? In this case, we are going to build rapport with our patients, we are going to ask open-ended questions, okay? So we can have as much as information we can, okay? So when we are interviewing our patients, we are going to have what? Very unbiased, non-judgmental demeanor, okay? We are going to ask open-ended questions, so your patient has the room to express and give you information. Sometimes we will cue them for elaboration, okay? As soon as you will start asking closed-ended question where the answer is yes or no, we are going to halt that interview. Your patient is not going to give you any more information because you're sticking to yes or no, okay? Ask for any stressful events, okay? For example, like any IBS flare-up. My daughter has test anxiety. On the day she has test, she spends most of the morning in the bathroom. That's a stressful event for her, okay? I'm on the other end. When I'm stressed out, everything shuts down in my body. My body goes into fight or flight, okay? For example, like, patient with IBS, like, they might have a IBS flare-up when they are under stress. If your patient has a cancer, they may be experiencing the grieving process. Like, maybe they're depressed, angry, or they're in denial. Your patients who have any GI surgeries, like, for example, like, they have a colon resection and then we put a colostomy on them. So now think about their psychosocial health and their, like, body image. Okay, then we have diagnostic assessments. We have like laboratory studies. We have, in the lab, we do the serum testing. The CBC is to diagnose for anemia and infection. So for anemia, we are looking at their hemoglobin, hematocrit, and for infection, we are looking at their white count, WBCs. So GI bleed is the most common cause of anemia. Just remember that. Okay, and then if their H&H is going down, we are suspecting what? GI bleed. We are suspecting GI bleed, and then we will interrogate the underlying reason for this GI bleed. Is your patient on, I'm sorry, any blood thinners? Like those NSAIDs? Okay, do they have any blood disorder that is causing GI bleed, or like ulcers? Any medications? So you see H&H, we are just not going to stop right there. We are going to assess further. Like, we always look for the underlying cause, okay? And if you suspect GI bleed in your patient, their H&H is going down, you suspect GI bleed, what are some of the studies that we can do? The occult stool test, you look for that hidden blood. in the stool. So if, and then we look for we ask the color, like, what is the color of your stool? Like black and tarry stool means what?
Blood.
It's a like old bleed, okay? It's an old bleed. If it's a frank red blood, it's a
It also
active
could tell
bleed.
you like if it's like a upper bleeding or lower bleeding, cause if it's travels through.
If it's upper bleed and it's going past, like, traveling like through your GI system, by the time they will defecate it, it's going to be like kind of black tarry stool. Okay, if it is lower GI, it will be red frank blood. Some of the examples for the lower GI.
Ulcers?
Or-
No,
Lower GI.
lower GI, lower, I don't know why.
If they have like any colon perforation,
Oh.
like expository,
Hemorrhoid.
enemas, okay,
Yeah.
rectal tubes, okay. Anytime we are kinda, advancing expositories or tubes, like, of their rectum, they are, like, your patient is at risk for like colon perforation, okay. Hemorrhoids,
What
that's
about like?
another example.
What is it called?
So if they have like polyps in their like descending colon,
Okay.
okay,
Is that considered the lower?
that's like lower if you're descending.
Okay.
So, for the upper GI, that's your ulcers and your stomach or duodenum or like, any injuries or like polyps or varices. So let's talk about some of these labs. Then we have our PT levels, like prothrombin time. We're checking for their levels of clotting. And that's like when you're suspected any GI bleed. You're going to check if their blood is thick, how thick or thin their blood is. So we are checking their PTINR. We will check for the BMP, that's their basic metabolic panel. It is to assess for electrolytes. Please know these labs and why, what are we checking? What are we assessing with these labs? So with BMP, we are checking for their any electrolyte imbalances. Okay, these imbalances could be related to any GI dysfunction. If your patient has diarrhea or they're vomiting, they are at risk for what? Fluid volume shift or and also electrolyte imbalance.
And metabolic syndrome.
Yeah. Calcium is absorbed in GI tract. Increased vomiting or diarrhea can cause electrolyte depletion as well. As I said. So two of the main electrolytes that we get concerned about are sodium and potassium. That imbalance. Then we have our liver enzyme. Liver is part of your GI system. So going back to our last lecture, I did talk about AST and ALTs. Okay, in this exam, I'm not going to ask you any like normal or abnormal lab values, just know what these diagnostics are for, what these labs indicate. So your liver enzyme, AST and ALT, they will be elevated, increased in any liver disorders. They will be severely elevated in conditions causing necrosis, such as hepatitis or cirrhosis. Okay. Then we will check for their serum amylase and lipase. So this will assess for any acute pancreatitis. So acute pancreatitis is what? Inflammation of the pancreas, and signs and symptoms would be sudden onset of abdominal pain, nausea, vomiting. Okay, and your amylase or lipase will start increasing, elevating in 24 hours, and they will remain elevated for the next 5 days. Severe pancreatic necrosis does not cause elevation in serum amylase and lipase. Why is that? Necrosis is we are killing those cells. We do not have enough cells to make these enzymes. So if they're not getting elevated and your patient has pancreatitis, then it means we are into the necrotic phase. Then we have our bilirubin. It's a pigment in bile. It is formed and excreted by the liver and the biliary system. So in your book, we are talking about the direct conjugate bilirubin and indirect unconjugated bilirubin. Please do not read too much into it, just know what bile is. For my exam, I'm not going to test you on that microbiology level. Just know what bile is, where it's formed, how it's excreted. Increased bilirubin indicates what? Impairment in your liver function. Okay, then we have our ammonia, serum ammonia. It is measured to evaluate your hepatic function. Again, your liver function we are evaluating here. And in our body, ammonia is used to build some of the amino acids. Okay, and it also gets converted to urea and get excreted through your renal system. Increased in ammonia equals to pancreatitis, cholecystitis, and GI disorder. What is cholecystitis? Inflammation of the gallbladder. Okay, and with your patients with cirrhosis, you will see increased bili. That's where you will see that yellow tinge, yellow pigment in their eyes and on their skin. And then also, like, with the cirrhosis or advanced liver failure, your patient's ammonia levels will go up as well. And your patient is presenting as what? Delirious, confused. Then we have our CA19 and CEA. These are your primary oncofetal and they're monitored to evaluate the efficacy of cancer therapy and assess for any recurring cancer of GI tract. Then we have our imaging assessments, x-rays. These are your plain films. So when your patient is going for x-rays, how do we prep them? Just kind of like jog your memory from last week. X-rays, any special
Well,
prep?
as for ATI, it says check, what is it, your,
Allergies to the iodine self.
For x-rays?
no, for x-ray, you have to check it's the right
Oh,
patient and like.
So patient prep, yes, of course we want to check all those rights, but then there's no prep except make sure they don't have any jewelry on because it will interfere with the imaging. Okay? There is no special post-procedure care. Then we have our flexible sigmoidoscopy. We will talk about the, sorry. Oh no, let's go home. Where is it?
No, I don't wanna go home.
You don't want to go home?
No, AT&T doesn't work, I don't have any internet, I don't have cell phone service. Nothing. Somebody invite me to their house.
So we will talk about the sigmoidoscopy and the colonoscopy, but just remember for this slide, just remember, like every 5 years, over the age of 45, we recommend that your patient should get like the sigmoidoscopy. So with the sigmoid, what are we assessing?
Would it be welcome to your house?
Sigmoid colon.
Okay.
Yeah, but where's the sigmoid?
The edge of the colon.
And part of the colon, okay?
What's the age of 45?
Over the age of 45. And then for the colonoscopy, again, over the age of 45, we recommend them to get a routine screening for the colon cancer. Then we have our CT and MRIs. For the CT and MRI, if it is done with the contrast or non-contrast,
I have to check for the iodine allergy.
check for the iodine
Or
allergy.
seafood allergy.
Okay.
No metformin.
So for a CT, just kind of like know the patient prep from last week, because the patient prep and the post-care remains the same. We will just kind of like have some focused GI issues again for the GI. Sometimes we have swallow barium studies, like we make our patients swallow barium.
Is that when they're MPO?
They are MPO. And then we will make them swallow barium, and then they can go to CT or to the x-rays. Mostly it's like a CT with barium. Okay, so the post-procedure care for this patient with barium, we encourage PO hydration and leg tips. Hydration, and then we give them any leg tips. Because we want this barium to get out of their body as soon as possible, okay? If you are working with a patient, just came back from the barium swallow study or barium CT, if you will see leg tips on their MR, on their MAR, please don't be alarmed, because they are there for a purpose. We are going to give these leg tips to get rid of this barium. Hydration, water.
I have a question.
Yes.
So for CT scan, for the colonoscopy, it's every 10 years after your initial one at 45, correct?
Yes.
And then what if you are like pre-cancerous, like if they find
Then
something
it's
that's every year?
It's every year, or
Every
it
4
depends, like, what is the progression like.
Okay.
And it's kind of like a wider discretion,
Right.
just giving your patient's prognosis. Okay, and guys, like with these guidelines, every literature, will be like different from one another, and then with every facility or organization, you will have different ground rules, but then, we're going to stick with what's in our textbook. Okay, other diagnostics, then we have endoscopy. What is endoscopy?
Is the direct visualization of the GI tract using flexible fiber That's the thingy that goes down your mouth, your throat, your whole.
So it's a fiber optic
Yes.
tube that we can advance to evaluate
And it allows the
patient GI
GI
tract. It is going to visualize, we can visualize bleeding, ulcers, inflammation, and tumors, and cancer of esophagus, stomach, and of the biliary system. EGD. Who wants to pronounce this word? Esophagus, so it is.
You got it right.
So it is to assess for the esophagus, gastric, so esophagus, gastric system, duodenum, okay? We're scoping and visualizing all of these, okay? If the GI bleed is diagnosed while you're doing EGD, provider should be able to inject any thermocoagulation or topical hemostatic agent to stop the bleed. Okay, if they will see any polyps or varices, if any polyps, sometimes they're able to clip them. If they're in varices or in GI bleed, it can also be cauterized during this procedure. We also use this study to collect any biopsy samples.
Yes.
And for the post-procedure care is your patient is going to remain NPO. Why? Because when we did this procedure, we did it under conscious sedation. We gave your patient some fentanyl, some Versed, and then also kind of sprayed their throat with some lidocaine to numb that gag reflex. To numb the gag reflex, so we can advance the scope down their throat, so they're not going to fight us. And the post-procedure care is to keep your patient NPO until their gag reflex is back. Okay? You're not going to give your patient anything by mouth until the gag reflex is back. Why is that? Patient is at risk for aspiration and pneumonia. Okay, and these scopes or procedures are done like outpatient. If it is done under conscious sedation, we advise our patient not to drive for next 12 hours or so. Then we have our ERCP.
Do we talk, is they gonna talk about how they end up with the crappy voice afterwards?
Sometimes it's abrasion, we can cause abrasion of their vocal cords. And that is just like for the EGD, for the endoscopy, it could be the same, if anytime we advance any scope down somebody's throat, even for the ET tubes, it is normal to have some, sore throat or kind of hoarseness. your voice. Then we have our ERCP. It is to examine liver, gallbladder, and bile ducts. Prep your patient the same as EGD, okay? And also check if your patient has any pacemakers. Like nowadays, pacemakers we have, they're good, they're compatible, but like those old pacemakers, they interfere with this kind of test. And if your patient has defib, pacemaker with defib, we want to turn off this defib, okay? Because it can be activated if we are using any those like electrical cauteries to cauterize any bleeding sites or anything that can set off this defibrillator, and then your patient will keep getting shocked. Okay, so we will advise to get this defib turned off. Can you turn the defibs off as a nurse?
No.
There's a magnet.
Yes.
I
Yes, you can.
Oh, cool.
Yes, you can.
Hell yeah, I can fun stuff.
Who said the magnet?
That's only when like
All
they
on
go
TikTok.
out.
Word?
So like on every crash cart, you will find kind of like a round magnet piece. It's on like every crash cart. So all you have to do is just kind of like scan on your defib and it turns off your defib. And then you can, as long as you have physician's order.
So for the VNS,
Huh?
for the VNS, do the same thing.
Mhm. So the first time I turned somebody's like pacemaker off, or sorry, the defib off, I was like brand new nurse working in like a memory care, and we had like lots of like palliative hospice type of patient. And we had this patient for like 2 weeks trying to die, but was not dying. You know, everybody was getting frustrated, including family. And then of course, like, you know, how much morphine you can give, and it was like, oh, he's about to, and the next thing you know, he's back. He's back. He's back. So later, again, like, you know, I'm brand new, like maybe 2 months on my job, okay? So later, like, you know, we confirmed, okay, patient has a defib. So anytime the heart is trying to stop, this defib is shocking
And
them
then
back
kicking.
into the normal rhythm and kind of restarting the heart. So maybe they were like brain dead, but then, you know, the defib kept them keep shocking them, and then just kind of like, okay, I'm back. Hello. So it was like, you know, yes, I learned how to kind of turn off those defibs and pacemakers so your patient can check out peacefully. But in this case, your patient is healthy. So make sure you have your physician's order before you turn this defib off, and then we want to make sure you turn it back on, because otherwise your patient will go into arrhythmias. Okay, then we have our small bowel capsule endoscopy. Anybody familiar with like a swallow study? Like somebody swallowed a capsule?
They do that for like the bariatric patients, they have like the whatchamacallit.
So we do bariatric patients, or when we are trying to kind of scan their entire GI system from like their esophagus down to their rectum. So we are looking for what, like ulcers, bleeds, polyps, you know, any abnormalities. So we will have our patient, so in our textbook, NPO, make sure your patient is NPO 12 hours before we make them swallow this capsule, and 2 hours after the test, after they swallow. And after they swallow the capsule, it's pretty much like a camera, okay? We will, after that we will encourage like maybe light meal, or just kind of like maybe a liquid diet.
Clear liquid.
Clear liquid diet, but like nothing that has a red dye, because that will kind of like imitate like bleed. It will look like a GI bleed.
No hot Cheetos.
And then you will have your patient will have like a belt around their belly, okay? That is kind of like scanning, and your capsule is transmitting pictures to that belt, and then after the study is done, we take that belt off and take the films out to kind of like, you know, look at pictures, what was happening in there. So when I took my NCLEX exam, there was a question about this capsule study, and it was asking me, okay, we will ask our patient, of course we are going to ask our patient, please let us know when you will pass this capsule out, because we want to know it's not getting stuck in their system, okay? So, of course, we are telling our patient, please let us know that you passed this capsule, okay? What would be the inappropriate response and trigger further teaching if your patient will tell you, oh yeah, I will clean it up and then put it on the side for you to take back. So that will be the inappropriate response. So as a nurse, you're going to tell them, please let us know when you will pass this capsule in
And
your
flush the toilet.
stool and flush the toilet. Okay, do not save it because we cannot make anybody swallow it again. Okay? Like, yeah, that was like one of my infections. I hope so, I passed. I passed. Okay, then we have our colonoscopy, traditional or virtual. So again, 40 years of age and routine. We will have a bowel prep. How many of you guys have bowel prepped a patient before colonoscopy? Or anybody in this room had a colonoscopy done? Huh?
Is that the goal actually?
Go lightly. Just don't let the name fool you. There's nothing light about the go lightly. Okay. So we will do the. What's happening? So for the bowel prep, we will have our patient on Go Lightly or anything that is prescribed for the facilities. And we will keep our patient NPO. Sorry guys. Okay, your patient is if your patient is NPO at least 8 hours prior to the procedure, okay? And we are giving them Go Lightly, so they are kind of flushing and cleansing of their colon, so there is no fecal matter sitting in there. So when your physician is going up their rectum with the scope, they can actually visualize the colon and not run into load of fecal matter. Because if there's any fecal matter, then you will not be able to assess for any growth or any GI bleed. So for the post-op care, there's pretty much there's nothing special if it is done under anesthesia, like a conscious sedation. So make sure your patient is awake enough before you give them any food. You tell them not to walk or drive for at least especially drive for next 12 hours or so, and then when they get up, we assess them how alert and oriented they are. Then we have our sigmoidoscopy, the exam of the rectum and sigmoid colon, and then we are doing this to evaluate for any GI bleed, and the prep is pretty much like the colonoscopy. Then we have sonography or your ultrasound. It could be endoscopy, endoscopic. And then we have liver spleen scan. In this scan, there's an IV injection of radioisotope that is taken up by the liver. Primarily it is taken up by the liver and then secondarily by the spleen. So we give this injection 15 minutes before the scan, and it is excreted via urine. So your kidneys are going to flush it out in 24 hours. So again, post-procedure care, we are going to check for their renal function. We will look for their creatinines, creatinine levels, and then we will encourage hydration for this patient. Okay. Digestive system diseases. We have colitis, pancreatitis, cirrhosis, we have peptic ulcers, gastritis, liver cancer, enteritis, and hepatitis. Okay? So just kind of get familiar, know what is colitis. Okay? The inflammation of the colon, infection, pancreatitis the same way, cirrhosis and hepatitis, they are for your liver. Peptic ulcers, your ulcers in your stomach, and gastritis, inflammation and infection. So your elderly patients are at risk for gastritis because they have low HCl, hydrochloric acid, or patient who is in metabolic metabolic alkalosis because they have been throwing up. They're losing acid, stomach acid. So then we have our physiological changes with age, stomach, large intestine. Just get familiar with this slide. Okay, disorders that can happen because of the stomach large intestine, pancreas, and liver with the age and nursing interventions. Okay, please get familiar with this slide.
Professor,
Yes.
are we still in chapter 40?
So this is kind of like the combination of chapter 48 and then some information from the other chapters. Because in exam, like I'm only touching this
Do we
stuff.
have it in the,
In the book?
It's not
This
included.
is a new PowerPoint. It was, Dean Vista.
I
She
just
provided,
downloaded.
it's not, no, it's not in the canvas.
Can we get it?
Yes.
Thank you.
Yeah, cause I can't find any of this in the book.
So with the Crohn disease, again, like, one of the chapters, like, there are like multiple chapters on GI disorders, so you're only picking out information that is for this exam, okay? So Crohn's disease, so it is kind of like genetic, if somebody has a family history of Crohn's disease, okay? It peaks at age of what, between 15 and 40, and autoimmune factors. Patient will manifest with, has manifestations of nausea and vomiting, abdominal pain, and distensions, and the tenderness in the right lower quadrant, okay? Severe diarrhea is one of the clinical manifestations, low-grade fever, bloody stools, weight loss, and severe malabsorption because their body is not absorbing all the nutrients, so it's just kind of like running through, everything is running through them. Okay. Then we have ulcerative colitis. I will post this PowerPoint up on in our announcement section in Canvas. Okay.
No, chapter 16 is on inflammation.
Then we have our appendicitis. Please remember this slide. I promise you there is a question. What is appendicitis?
Take a picture.
What are your patient's presentation? Okay, pain is one, okay? Increase in white count. And please know the McBurney's point. Okay, we are looking for that, like what, rebound? Tenderness? So the positive McBurney sign is when significant pain is elicited by palpating this area in the right lower quadrant. So it's like this is your iliac crest, this is your navel, and right the middle point. That's your McBurney's point. Okay, if you palpate in this area and your patient flinches or they withdraw, means we are concerned about their appendix here. Okay. Which claim statement regarding intake will the nurse assess as a priority? D. I take ibuprofen 3 times daily for arthritis. So ibuprofen is what are we concerned about? GI bleed. After abdominal surgery, which nursing assessment question is priority after the abdominal surgery, post-op? Okay? Because we want to make sure your patient is passing gas. If they're not passing gas, their bowel tones are hypoactive. What are we concerned about here? Ileus. When administering a new GI medication to an older client, what outcomes does the nurse anticipate? We're talking about an older client, okay? So it's the B. We want to monitor them closely for any toxic levels may develop, because as we know, we did talk about it, like, as they age, their hepatic clearance goes down. So it means they're going to start building up medications back in their system. So with any new medications, we are concerned about how it metabolizes. Okay. I go, let's go for lunch. Oh yeah, key points. Okay.
Why do I have that?
We want to look for like CT scans, like all the diagnostics we had, patient prep, and post procedure. And that are your CT, MRIs, EGDs, endoscopy. GI bleed assessment, we did talk about it. So with the GI bleed, HNH is going down, okay, from the vascular end. What are we concerned about? Their blood pressure. Because if they're losing fluid, if they're losing blood somewhere, we are losing fluid, okay? We're losing volume. So you will also assess your patient for any orthostatic hypertension. How do we assess for orthostatic hypertension? Okay, check their blood pressure in laying down, sitting, and standing up position, and then you look at how, like if there are any significant drops. Appendicitis, I just gave you guys the answer for that question, so know it.
The Bernie's dude?
Huh?
The Bernie's dude? The burning?
Like Bernie's point. Okay, and that slide we talked about like sequence of abdominal assessment. So what is the sequence of abdominal assessment? Inspect, auscultate.
The doctor does the last one.
So again, for this one, go by your textbook. Inspect, auscultate, percuss, and palpate.
And the quadrants too?
Yes. Yes. Eating disorders.
Bless you.
Okay. We will talk about elimination towards the end of the day after covering the urinary system, so there will be more things coming out of that. That's it.
Professor, it's a surprise. So you mentioned something about the variance level earlier, so your hydration and variance quality. Oh, that's it. Good morning. Okay. I know, I don't know.